Welcome my dear to this your channel clinical consultant, with this third topic of anemia. This time I bring you this topic called, iron deficiency anemia. Without further ado, we can continue. Definition. Iron deficiency anemia is anemia secondary to inadequate iron intake or excessive blood loss. Epidemiology and demography. Dietary iron deficiency occurs in infants as a consequence of unsupplemented milk. It is also common in women of childbearing age as a result of very intense menstruation or during pregnancy. In this case, the demand increases. Iron deficiency is the most common nutritional deficiency in the world. The prevalence of iron deficiency is highest among children aged 1 to 2 years, who represent 7%, and adolescents and adult women between 12 to 49 years, who represent 9 to 16%. Signs and symptoms. Most patients have a normal physical examination. Although it can be observed paleness of the skin and conjunctiva, as well as paleness of the palms of the hands. Etiology. The etiology is very varied. Loss of blood through the digestive tract or menstrual bleeding, although the latter is rare. Iron deficiency in the diet, although rare in adults, usually occurs. Iron malabsorption in patients with gastric or small intestine surgery. Repeat phlebotomies. Increased demand for iron as occurs during pregnancy. And other causes could also be traumatic hemolysis, caused by alterations in the function of the heart valves. Idiopathic pulmonary hemosiderosis, this is how iron sequestration by macrophages in the lungs is known. Paroxysmal nocturnal hemoglobinuria, caused by intravascular hemolysis. Differential diagnosis. There will be a difference between this anemia and anemia of chronic disorders. Sideroblastic anemia. And of a thalassemia trait. Medical assessment. The diagnostic evaluation mainly includes laboratory studies. Most iron-deficient patients are asymptomatic in the early stages. As the anemia progresses, the main symptoms are fatigue, vertigo, dyspnea on exertion, pagophagia, that is, a need for ice intake, and itching. The patient's history will also indicate something that may suggest a digestive hemorrhage. It could not indicate the presence of black and pestilential stools or glittering red stools or with drops of blood. In these cases the signs would be called melena, hematogia, and if this indicates that you have vomited blood, the sign is called hematogia. Lab tests. Laboratory results vary depending on the stage of deficiency. The absence of medullary iron deposits and the decrease in serum ferritin are the initial alterations. Decreased serum iron concentration and increased TIB are the next abnormalities. Microcytic hypochromic anemia exists when iron deficiency is significant. Peripheral blood smears from iron-deficient patients usually show red, hypochromic, and microcytic cells with a central, pale area, anisocytosis, and poikilocytosis in severe cases. Laboratory abnormalities compatible with iron deficiency include low ferritin with increased red blood cell distribution with values greater than 15, low BCM, increased TIB, and low serum iron concentration. The hemoglobin content of reticulocytes can be a good screening test for iron deficiency, can be measured on an automatic hematology analyzer, and is a relatively cheap and quick way to detect iron deficiency. Non-pharmacological treatment. Patients should be encouraged to eat iron-rich foods such as liver, red meat, and legumes. Acute treatment. Treatment includes ferrous sulfate 325 mg orally daily for at least 6 months. Calcium supplements can reduce iron absorption, therefore these two drugs should be staggered. One day it is taken and another day not, and the day we take one, the other is taken. Referral iron treatment. A poor tolerance is reserved for patients who do not take oral medications or who have poor absorption. Packed red blood cell transfusions are indicated in patients with severe symptomatic anemia. In these cases, when patients present with angina, bone, chest pain or anemia that threatens life. Chronic treatment. The patient must maintain iron supplies for at least 6 months or more to correct the body's depleted stores. Forecast. Most patients respond rapidly to iron intake with an improvement in the complete blood count and general condition. The digestive side effects of iron are common and may require a dose reduction every other day. Derivation. Consultation with a digestive system to rule out malignant tumors is recommended in all patients with iron deficiency and suspected gastrointestinal bleeding. And as important considerations if iron deficiency anemia is diagnosed, it is mandatory to try to locate the origin of the blood loss. Thank you very much for watching the video. The next video it will be anemia, autoimmune hemolytic. Thank you very much for watching the video. Like and subscribe, comment if you have questions. Greetings.